Well, Tracy, thank you very much, and thank you all and Elsa for the invitation. It's really quite humbling to be here because I'm actually among many people who I admire the most, and the work you do is really extraordinary. So please, all of you, be encouraged to support the work of the amazing team that you've been introduced to just now. So sometimes when I talk to my medical students, I ask them to try and put themselves in the position of being the patient. And today we're going to turn the tables a little bit. I think it's very good for us as physicians to try and imagine what it would be like to actually have the conditions that we see from one side of the fence, but many of you actually suffer from the other side of the fence. And of course, it's not always so straightforward to do that. But I wonder how easily you could put yourself into the position of the physician and see how you would think if you were trying to treat some of these conditions. And so that's what I'm going to ask of you today. I don't want to get too complicated and technical, but on the other hand, I know from past experience and having had the pleasure of interacting with many people from this organisation that you're extraordinarily sophisticated, in fact worryingly so, much more so than most of my physician colleagues, in fact. So I'm sure that you'll cope with this, but if you're not, please stick your hand up and say, because I don't want to bamboozle you. But I do want to cover some concepts that I hope you'll find interesting. So you've already heard that tomorrow is a very special day, actually, because it's an anniversary. October the 12th, in fact, is World Arthritis Day. So there's a European body called EULAR that initiated this, and it's really to raise awareness of this dreadful condition that affects a very large number of people, and of course you all know this better than most. And so it's a very auspicious time to be talking today on the anniversary of World Arthritis Day. But you may know, do any of you know any other auspicious moment that's occurring tomorrow? Perhaps some of you do, some of you don't, but I'll give you a little clue. So here's a clue. Here are 3 boats making their way across the ocean. Absolutely, yes. So tomorrow, in fact, is Columbus Day. And 520 years ago to the day, he set off around the world, and one of his crew members, it was probably a crew member rather than Columbus himself, sighted the so-called New World. And they probably sighted the Bahamas, so in some ways you might think they were quite fortunate until you realise what their diet was for the preceding 8 weeks. And this led to the discovery of 2 previously unknown continents and, of course, the birth of a whole new civilization. So it's a very auspicious day tomorrow for 2 reasons. Columbus Day and it's World Arthritis Day. And I hardly need to say this to you, but let's just start off with some facts to remind you of certain things. So there are more than 200 different types of arthritis. The condition is more prevalent in women, and I think that's reflected in our audience today as well. More than 10 million adults, 6 million women, 4 million men consult their GP each year with arthritis and related conditions in this country. That's an awful lot of consultations. More than 6 million people have chronic back pain. I know the focus today is rheumatoid, but don't forget there are other kinds of arthritis that are very disabling. And actually, arthritis is the biggest cause of pain and disability in the UK, would you believe? And it makes it the most common condition for which people receive disability living allowances, and therefore it has health economic impact. And you've also heard that there are going to be new activities around children within this organisation, but in fact 15,000 children in the UK have ongoing problems with juvenile arthritis. So it doesn't spare any age. It can occur from infancy right through to grand old age. So I don't really need to ask you this question because you all know the answer, of course, but what's the most common cause of chronic inflammatory polyarthritis? Now this all sounds a little bit technical. Chronic means it goes on for a long time. Inflammatory, you know what that means, there's inflammation involved. Poly means many, more than 5 in this context. And of course you all know what arthritis means. And the answer is rheumatoid arthritis. So this is an important condition, not only to many of you as individuals, but to the healthcare economy and to our society. And it's become increasingly important in some ways, or elevated in the eyes of society, because we can do a lot about it. But there's a strange irony. We can do more about it now than was possible in generations gone by, and that's wonderful. But the very success of the treatments that have come about, in some ways, are holding us back from progressing further and going for cure, because many of the pharma companies think that rheumatoid arthritis is all sorted out, and I'm sure that every one of you in this room will know that that's not the case. So sometimes patients who see me nowadays who've had arthritis for 10 years or so may look pretty normal when you look at their hands. And many of you will be aware that this very disabling form of arthritis, this is how it was generations ago, and it may still be so for some of you here. The fortunate thing is that when a patient comes to see me today, you can look them in the eye and tell them absolutely honestly, it's very, very unlikely that this will happen. But you can't promise them that. We can't cure these conditions yet. And so what we've learned is that it's important to switch off the inflammation that causes all this damage and disability. So we want to switch off the inflammation as completely as we can and as early as we can and consistently over time. And that's been one of the big drivers to many improvements in the outcomes for rheumatoid arthritis, but also some challenges. And that's where I'm going to try and put you in the doctor's position so you can see what you might do. So here's the hand of someone who's got dreadful rheumatoid. Here's the hand of their grandchild who fortunately is healthy. And of course what they want is to make sure their grandchild never actually develops this sort of condition. And so we've got a long way to go still before we can cure these disorders. But I want to tell you about some advances, and one of these is the so-called treat-to-target concept. Now I know that Elsa and many of you will be experts on this, but can I ask, how many of you have ever heard of this? Stick your hand up if you have heard of it. Okay, just a few of you. I'll explain what it is in detail. And one of the things about treat to target is that we have a goal as physicians, and the goal is to actually get a remission. That means to completely suppress and switch off the inflammation if we can. But it doesn't always work, and I want to talk a little bit about that with you and about how we should set targets, working together, physicians and patients together, to get it right if we can. What do we actually mean by remission? There's been an evolution of thinking about remission, and I'll tell you a bit about that. But most importantly, is it actually achievable? There's not much point of having a goal if you can't actually achieve it. So if you have, in the Olympics, you set a target, you say you want to run 100 metres under 20 seconds or whatever it might be, that's fine, as long as someone can do it. But if in fact you can only do it if you're a four-legged cheetah, there's not a lot of points. So we have to think through very carefully what this is all about and what's achievable. So I'm going to discuss with you the pros and cons of treating to the currently recommended targets and get you thinking like doctors as well as like patients. And should we actually rethink some of the contemporary guidelines? And should we also consider things from a more holistic standpoint? So should we see optimising inflammation as just one component of a much more holistic package of care? That's my own view, but I'd be very interested to hear yours. So just to deviate for a minute, I don't know how many of you like artwork. I'm not terribly knowledgeable about art, but I do appreciate good art. And I think this individual has actually painted a self-portrait very beautifully. And my interpretation as a complete amateur is that he's a rather angry young man. I don't know what you think. He looks a little bit ferocious, doesn't he? But it's beautifully painted. You can't quite see the brush strokes in this light, but it's actually a lovely portrait. And here's another portrait of a rather softer looking gentleman. Looks a little bit perhaps kinder, dare I say it. I don't know whether that's just my imagination, but perhaps softened by years. And in fact, I can tell you that it's the same man. Now, Elsa's not allowed to answer the question, but does anybody know who it is? Yes, it's Renoir. So Renoir was a famous painter. And in fact, he was one of the people who was involved in the Impressionist movement. And I don't know if you've ever seen any Impressionist paintings, but they look a little bit stipulated as little points with a paintbrush. And you might have wondered why that is. I've heard artists talk a lot about this. But what they might not realise is this is how he had to paint. So here is Renoir, and this is what life was like in the era before we had contemporary treatments for rheumatoid. So he was wheelchair bound, he had a dreadful disability, and his paintbrush you can see is strapped to his hand. You can see it a little bit better here. So obviously a very old painting. It's astonishing to my mind that he could paint with such beauty and yet have such a marked disability. And so in many ways there's a lot of interesting lessons about this. I'm not trying to be sycophantic now, but I can let you into a little secret that all us doctors know that it's a pleasure to do clinics for patients with rheumatoid because the patients are all so nice, as far as you can ever generalise. Now this is probably partly a coping mechanism, I suspect. But actually, I think it is part of this syndrome that people are remarkably accepting and tolerant of it. And if you look at some of Renoir's paintings, and again, I'm not an expert on art, but to me, this is full of joie de vivre. I don't know if you would agree, but there's a lot of movement and life and happiness here. This isn't the painting of someone who's really feeling very sorry for himself and missing out on life. Look at that, absolutely beautiful painting. And yet there's some interesting features. So if you look closely, now again, I stress that I'm a non-expert, but look at this lady here and this one. To me, the faces are almost identical. And this one, very, very similar. So was it that Renoir couldn't paint faces terribly well because of his disability? I don't quite know, and yet he captured all the life and movement and liveliness in these different pictures, painted at different times. So Renoir was once asked this question. He was asked, how can you continue to paint while in the agony of the pain of rheumatoid arthritis? And his response actually was quite remarkable. There he is with his carer, also one of his models. You'll see her in some of the paintings, usually with some clothes on, but not always. It was all very platonic, I might tell you. But his response to the question was this: the pain passes, but the beauty remains, which I think is an absolutely extraordinary quote, actually, and very, very beautiful in its own right. But now you've seen what rheumatoid was like in the past, and I'm very conscious of the fact that many of you will know from personal experience what it's like in its worst expression, even now in the current era. And I want to take you on to the way doctors think about treating it in order to get the best out of therapies we have, and then see what you think about the various policies that have come into being and guidelines that have emerged. So many of you who have rheumatoid will know that the nature of the inflammation is up and down over time. It relapses and remits is the way we doctors talk about it. So sometimes it's bad and sometimes it's not so bad. And very often when you first develop it, it gets very bad quickly and then it begins to tail off. And it tails off because your GP gives you anti-inflammatory drugs, which actually work reasonably well. However, if you look at disability, and maybe some of you suffer from disability, what you'll notice is over the first few years of the condition, but you can see over the first 5 years or so, that disability actually marries up with inflammation. And you will know why this is better than I do, because if I were to try and do up my shirt buttons when I put my shirt on in the morning with a pair of boxing gloves on, it would be very difficult. And some of you know this. When your hands are really swollen and inflamed, it's like having gloves on or worse. But over time, you'll notice that the two graphs differ. And why is that? Well, what doctors talk about is measuring the total dose of inflammation that you suffer in your joints. So you have inflammation over time, and that's like the area under the curve of inflammation. So if any of you are mathematicians, we call this the integral. And what you can do is add up all the little bits of inflammation that occur over time, and you get this straight line, more or less. And it tracks the way your x-rays get worse unless you have treatment that prevents this. So in other words, early on in the disease, it's the inflammation in the joints that cause the damage, but later on, 10 or 15 years into the condition, which lasts a lifetime, as you know, it's actually the damage that causes the disability. So there are these two things. So if we want to stop this, we have to switch off the inflammation, but also prevent the damage. That's what we need to do. Now, one of the biggest advances, and I'm very proud to say I had some involvement with this, and this came about almost 2 decades ago now. It was anti-TNF drugs, which are now, of course, routinely available in the clinic, but only providing you meet strict criteria, which are set by our government to give you access to these. And this is what happens if you have methotrexate alone and very bad rheumatoid, but this is the mean number of patients. If we would take everyone in the room and take the average change in X-ray, it progresses over time. Now, if you get an anti-TNF treatment, it almost completely switches this off. This is actually from a real live clinical trial. So we're looking at time measured in 2 years on the horizontal axis. Whereas if you delay the onset of anti-TNF for the first year and then get it after 1 year, you again switch off future damage, but what's already happened you can't reverse. So I hope that makes sense. So that's the good news, and one of the reasons anti-TNF treatments were a revolution, a breakthrough, because they switch off this damage, so we were all very pleased. But it's actually a bit more complicated than that. Now, our friends in the pharmacology world, in Big Pharma, make a lot of money out of these drugs. They cost £10,000 a year per patient, and that's why they're in effect restricted. And The thing is that a pharmacological rep will come along and say, well, if your patients are all going to progress like the green line, shouldn't they all get these expensive drugs? But actually it's a bit more complicated, because when you look at individual patients and the way their joint damage goes, what you see, I'm just going to point this out here, is this group on the far side that actually are progressing. All these people with a flat line on 0 actually aren't progressing at all. They may have inflammation like wearing boxing gloves, but they're not getting the damage. And so people like me have to try and be smart enough to know to give the right treatment to the right individual. Why would we spend £10,000 a year on a treatment to stop damage when actually you're not getting any damage, when £100 a year treatment will do? And this is the kind of health economic thing that we do have to think about and be wise custodians of a limited resource, because the NHS is not, you may have noticed, in a very good financial position. So this is the situation that about 20% or so of patients do get this damage over time, but others don't. And we've got to get smarter about this so we make sure the right treatment gets to the right individual. Now, this is how it was before or after Renoir, actually, but before any of you certainly had rheumatoid. In the 1930s, bed rest and whiskey was very popular. Some of my patients still find this very popular for certain reasons that I can't imagine what they might be. Then in the 1940s, there was a breakthrough with the advent of glucocorticoids, and these were amazing drugs, steroids. There were pictures of people who'd been in wheelchairs or bedbound, leaping up out of their beds and dancing around, that there was big doses of steroid. And at that time, it wasn't known these drugs could also have horrendous side effects. So whilst they're great drugs, they can be dangerous drugs as well, so they have to be used carefully. Then any of you who remember the 1970s, I'm not sure if they were the good old 70s or the bad, but we had some nasty toxic drugs that do work, but we don't use very routinely now. And then in the 1980s, there was a new drug called leflunomide. Some of you may have heard about that. And then it was in the 1990s that anti-TNFs and biologic therapies came about. And we're about to see very soon an era of new drugs again, I think, called small molecules. These are tablet type of drugs, but which have a very powerful effect. We don't yet know for sure whether they'll be launched, but it looks very likely. So the thing about all these drugs through from the 1940s to the 1990s is that they worked a little bit, but they were also quite toxic. They had side effects, and that meant that we had to be careful about how we use them. And that's medical jargon, pleiotropic effects, but it means they have many effects, some of which are beneficial, some not, and we didn't really know how those drugs worked. But it wasn't until the 1990s that we developed drugs where we really understood how they worked based on the understanding of the biology, what actually causes rheumatoid arthritis. So having got all these new drugs which work very powerfully, then of course committees get together, committees of doctors. Sometimes they involve expert patients as well, such as Elsa and various of your colleagues, and they come up with these guidelines. And these are guidelines that were published in 2010, and broadly speaking, they're very good. But I'd just like to explain these to you. So some of you may have personally experienced this, but not known that you will be treated according to guidelines. If I can get the arrow to work. Basically, if you have rheumatoid arthritis, the idea is that the physician has a chat with the patient about what the realistic goal of therapy will be for the individual patient. And the ideal goal would be remission. That means to switch off arthritis as completely as you can. And if the patient agrees with that and the doctor agrees with that, then you go for it. But in order to go for it, it means having more and more drugs, that you work your way up with more drugs until you get this remission target. But of course, one of the trade-offs might be that if your drugs are increased, the dose is increased and more is added in, there may be some side effects. So you always have to weigh the good effects and the bad and see what's right for the individual. So the guidelines recognise that not everybody's going to achieve remission, and if you don't achieve remission, then you go for low disease activity, which means you'd accept a few swollen joints here and there, but even so, you'd be an awful lot better. And if you achieve these targets, that's great, but if you don't, you go on changing treatment until you actually achieve them. Now, the question is, does this really work in practice, or do we need to think about other things? So what do we mean about remission? Well, remission is actually defined usually by what the doctor or nurse measure. So some of you may have had this done, where they actually look at your joints and they squeeze them. If it hurts, you say ouch, and they write that down as a tender joint. If it's obviously swollen, then you write that down that it's swollen. They measure a blood test to see how much inflammation shows in your blood. And they might ask you to write down how you have felt in the last week by marking a cross on a line, which is your so-called global health assessment. Does that sound familiar? It may not to everybody, because not everybody has done this until recent years. So one of the very good things about Treat to Target is it's made physicians actually take these measurements and then do something about it. Because there was a time when physicians worked out how the patient was just by simply asking, how do you feel, Mrs. Jones? And I've already let you into the secret that rheumatoid patients are incredibly nice, but Mrs. Jones often is much more concerned about the doctor. How was your holiday, doctor? How are your family? Well, all these are very nice things to be able to discuss as well, but sometimes it can deviate from the main point that the patient claims they're fine when actually they're not. And some of you, if you're honest with yourselves, will recognise that. But the question is, have we got the right target? So here's some chap with all his arrows pointing at a target, but which one is he actually trying to hit, or is he trying to get them all at the same time? Well, let me just explain this to you. If any of you have had your DAS measured, let me ask you, how many of you actually know what your last DAS measurement was? So that's very interesting. Just a handful of you, maybe 5 of you in the room. So very small number out of the total number of people in the room. There's no reason necessarily why you should know, because your physician may measure it, or your nurse, and they may do something about it without your knowledge. But the fact is that if you have a very high disease activity, that's bad news, and something needs to be done, and nearly always something can be done. That's the good news. If you've got moderate disease activity between 3.2 and 5.1, again, something can be done. But the targets in the guidelines are to get you right down there at this low level of disease activity of 3.2 or less. And so that's all very well as far as it goes. There are other ways of measuring your disease activity. There are some that don't involve taking a blood test. I won't go into technical details here, but you can do this just simply by adding up the number of tender and swollen joints you have. And this means, of course, for some patients, they can do this themselves at home. They don't need to come and see a nurse or a doctor. They can measure it themselves. And similarly, if you have some of these measures which don't require a blood test, one of these has a blood test, one of these doesn't. But the point I'm making here is, depending on which physician you have and whereabouts in the country you come from, it may be perfectly acceptable to work out disease activity without needing a blood test. And again, we can work out just how bad things are at the moment. That's important, because once we know what the real state of play is, we can do something about it. And then there's another. Have any of you heard of Rapid 3? Have any of you done this? I know Elsa will have heard about all these things, of course, but not necessarily everyone. Well, this is another way of measuring disease activity that patients can do themselves. And it's just based on marking on a 10 centimetre line where you are at the present time, based on your function, your pain, and your global estimate of your state of health at the present moment. And actually it works incredibly well. So sometimes hospital managers and physicians will say, well, we've not got enough appointments, or in my particular trust they're saying you're overperforming, you're seeing too many patients, we can't have all this many slots. That of course you can have telephone services which have been set up around the country where the patient just measures these 3 things very simply, and it gives some idea of how you're doing. Why does this matter? Well, the thing is, if you're genuinely doing really well, probably there's no need to change your treatment. But if on the other hand you're not doing really well, what we don't want is damage to take place that's creeping under the radar. And therefore you need to see a physician and have something done about it. So with this Rapid 3 again, there are ways of looking at the score you give yourself and working out how well you're doing. And some of you might even like to try this, and we can talk more about it later if you're interested. But here's the thing, that if you look at how people do over time, sometimes it tells a slightly different story. So on the left-hand panel there, in the dark green, we're looking how patients are if they've got relatively low disease activity when they first pitch up at the clinic. And then we're looking 3 months later to see how they're doing. And you can see that, in fact, overall, more people have low disease activity because hopefully their treatments are working. But if you look at the ones who have high or severe disease activity on the right, you can see it doesn't change so much actually over time. And in fact, although it goes down, you'd want it to go down, so there's a big change because people are changing from high disease activity to low. But it doesn't go down all that much in many cases. So it does illustrate we've got a bit of a problem. And we have to ask ourselves, just how realistic are these targets? It's great to want to put someone into remission, but if I've had a long conversation with the patient about what I want to do by escalating treatments, and you go away and you read the patient information leaflet and it shows all these nasty side effects you worry about, and you might be worried about some of the complications that might arise from rheumatoid arthritis itself. and you come back to clinic and say, well, I've experienced all these side effects, my DAS28, my disease activity score, still hasn't gone down to the target of remission, what am I going to do? And the answer is there's lots we can do, but I'm very much against just treating the numbers, because we're dealing with people here, we're not dealing with numbers. So the good side of this is that if you treat the numbers, you get better outcomes because you don't just ignore inflammation when it's there. But the bad side is sometimes we get so hooked up on the numbers that we forget the person. And I'm sure some of you will have experienced this. So now I'm going to pretend you're all actually medical students or doctors and show you some real-life clinical data from trials with the best type of treatments that we have. These are anti-TNF treatments. And what they're showing you is that if you develop rheumatoid in the last 3 months, so if you've got early active rheumatoid arthritis, what are your chances of getting remission? And there are the figures. So in one of these studies that was done some years ago, it was 1 in 5. From one of the most recent studies, it went up to half the patients could achieve remission. But that's if you've just got arthritis now, if you catch it very early. So the good thing about this treating to target is you get some nice figures, but the bad thing is that actually, what about the patients who don't make it? Over half the patients usually are not achieving that remission figure. So what are we going to do about that? Now then, let's have a look at it another way. So you can plot out on a graph the spread of different disease activity scores that people get after they've been in a trial for some time. So here you can see different levels. So this is the median, that means that's what most patients achieve, and actually it's above the low disease activity range. And the error bars either side give you the range of spread of disease activity scores achieved. So that's what most people do. So about half the people are above the remission criteria. But you can see a very small number of patients are down where we want to be, within the target that the guidelines recommend. But what about all these people way up here who haven't got anywhere near the target? And actually it's the majority. So there's a bit of a problem. Now so what I've been showing you so far is clinical trial data from people who've newly developed rheumatoid. Now, I suspect for any of you in this room who have rheumatoid, you've had it for some years. And so you'll know that if you're about to start on an anti-TNF biologic, your situation may be different. So what are the facts? Well, the facts are, if we look at these different studies in this column here, where it says remission, this basically gives you your chances of achieving remission, somewhere between 1 in 5 and 1 in 3. So that's good if you're one of the thirds who achieves it, but it's not so good if you're one of the 2/3 who don't achieve it. So what is the point in setting a target of remission when actually 2/3 of such patients are never going to achieve it? So I'm not trying to knock the idea of going for gold. Absolutely we should go for gold, but we just need to consider the whole person and the personalised goals as well as the measured goals in terms of numbers of swollen and tender joints and so on.